Okay, Madam Chair.
Thank you, Mary. It is now 10 o'clock. I'll call the meeting to order. Welcome to the Grey Bruce Board of Health meeting for Friday, May 27th, 2022. Mary, can you take the roll call, please?
Alan Barfoot.
Present.
Sue Patterson.
Present.
Brian Milne.
Present.
Brian O'Leary.
Present.
Chris Peabody.
Present.
Yeah. Luke Charbonneau.
Here.
Helen Claire Tingling.
Good morning, Mary.
Salwyn Hicks and Janice Jackson sends their regrets. Nick Saunders. Nick Saunders.
Okay, thanks, Mary. We do have quorum, so we'll start. Amendments to the agenda. Does anyone have any amendments? Seeing none, I will ask for approval of the agenda as presented. I need a mover and seconder, Brian Millen and Chris Peabody, all in favor. That's carried. Okay, moving right on, educational notes. You'll remember last month we started with governance and management roles and responsibilities. And before we start that, and I'm corrected, I must ask if anyone has a disclosure of pecuniary interest. And seeing none, of course, if one should arise during the meeting, you may declare it then. So educational notes, we highlighted the first three items for governance and management roles and responsibilities. So this month, we're going to do the final three items. So this is included in our orientation package, but I'm just going to highlight it. So the board's role for coach and mentoring the CEO. We are there for decision support. We share performance feedback and advice. We ask probing questions on behalf of the owners or customers. And I would like to say that's our residents and our Grey Bruce stakeholders. And we function as coach, guide, and mentor. The CEO's role for organizational and people alignment involves workforce acquisition, retention, and performance management. It involves alignment of processes, systems, structures, culture, and skills to achieve the strategy. And coach direct reports and model learning, and provides the right balance of leadership, management, and empowerment and accountability. And then if we go to the board's role to select and support the CEO, we review, evaluate, and monitor the CEO's performance and compensation. We, under the role is succession planning and CEO development, and we invest in learning and growth of the board and the CEO. The CEO's role is to build capacity of staff. That involves investing in the learning and growth of staff. Leadership and talent management is under that role, as is model learning, and to practice development, facilitation, and coaching. And then if we look at compliance, the board's role to ensure compliance is with regulation requirements, quality care and risk management, stakeholder and funder communications, and to hold the CEO and the chief of staff accountable for outcomes. The CEO's role is to manage execution, and that's through performance measurement, reporting, and review, and to build a partnership with the chief of staff, the senior team, and the board, and determine leveraged actions to close the performance gap and practice stewardship for success. And I do want to say that I mentioned it at the beginning, this page is in the orientation package, which is coming later on the agenda. And it's important to note, like if you go further into that orientation package, that we are governed by the Health Protection and Promotion Act. And James Lenore, the lawyer, explains the difference between the Municipal Act and the Health Protection and Promotion Act and how it affects the board. So I encourage everyone to make sure they follow through with James Lenore's presentation, along with the rest of the package. So at this time, I'll ask if there's any questions or comments with regards to these roles and responsibilities. Dr. Era, did you want to comment or you're good?
I'm good, Madam Chair. You covered all aspects.
Okay. All right, we'll move on. So item 6 is adoption of minutes. And these are minutes from last month, Friday, April 22nd. Is there any discussion? Alan? You're going to move it?
Going to move it, Madam Chair.
Okay, moved by Alan, seconded by Brian O'Leary. All in favor? That's carried. Thank you. Item 7, correspondence and news releases. Correspondence 7.1, Dr. Era.
Thank you, Madam Chair. We have this month 3 correspondence items. 2 of them are related to an item that we addressed in our last meeting, which is the endorsement of recommendation for the province of Ontario that came from Simcoe-Muskoka District Health Unit to address the opioid crisis. And these 2 communications or correspondence came from Bureau of Public Health and Windsor, Essex. The 3rd correspondence, which is number 2 on the list, is from Peterborough, and it is endorsement of a previous correspondence that came from Windsor, Essex, that our board addressed also in previous meeting, which was related to the orders, the regulations under the emergency order that would enable Health Unit to have more latitude in addressing union issues. Nevertheless, this does not apply or does not become relevant to the health unit we're in. We have optimal relationship with the unions, and the emergency response stage has been completed. So we're in the recovery, and those regulations, although might serve other parts of the province, are not relevant. My recommendation, Madam Chair, to the board is to receive all if there's no other aspect of the correspondence that require further consideration. Thank you.
Thank you. Any comments regarding the correspondence? Seeing none, we'll move on to the media releases, and welcome, Denis.
Thank you. Through you, Madam Chair, there are 5 news releases in today's agenda package. The first relates to ticks and Lyme disease and includes information on the vector-borne disease, how it can spread from black-legged ticks that carry a specific bacteria to people, as well as ways to avoid tick bites, what to do if bitten by a tick, and how to identify a tick. The second news release is about changes to Ontario's publicly funded routine immunization program. As of April 1st, pregnant individuals can receive 1 dose per pregnancy of the pertussis-containing Tdap vaccine. And the goal is to provide newborns with protection from pertussis, also known as whooping cough, as the risk of severe illness and death occurs mostly in infants. Also, starting next school year, the province is expanding the eligibility period for the school-based hepatitis B immunization program to the end of grade 12, providing students who missed the vaccine in grade 7 more time to receive the shot under the publicly funded program. And there are also news releases on public health continuing catch-up in-school routine vaccination clinics in May. One to request the public's help in identifying the owner of a dog after a dog bite incident in Southgate, and one on a Novavax clinic that took place May 20th for individuals who added their names to a waiting list for this alternate COVID-19 vaccination. And those are the news releases.
Thanks, Denis. Any discussion with those releases? Brian Millen?
Thank you, Madam Chair. First of all, it wasn't my dog. Secondly, my question is regarding the two media releases regarding school vaccination. Of course, a lot of students, I suppose, missed the routine vaccines that would normally have given them on a certain timeline. Do those students get formal notice from the health unit that they've missed and they require those, or is it up to the students to acknowledge that they've missed their vaccine and they're eligible to get it? I'm just wondering how the notification process works there, I suppose.
Okay, Dr. Era?
Thank you, Madam Chair. If I can refer to Dr. Zayed, just because the process would include both, but I'm not sure where we're at in that file.
Okay, Dr. Zayed.
Through you, Madam Chair, this process is actually started with the consent from to parents. So there is a formal consent that is sent to parents as vaccine needs to be consented by parents, and then we have this consent uploaded in the Panorama, which is a software that we use for vaccine. So any child who will need to get this vaccine, we have a process first to started with the Board of Education. Board of Education informed the principals, and the principals started to get these parents letters informing them that we are going to start the vaccine in schools. And we did not give, we intended not to give COVID vaccine in schools, so that we consider people who are not really consenting on that and make it only in the community center. So we only exclude the vaccine that are VPD vaccine for ISPA or the Student Pupil Act in schools. So parents are aware beforehand. And also we send a media release telling parents that if we have consent on one series, this means it is a consent by default to the rest of the series. So if it's 3 series vaccine, we are not getting a consent for everyone, but we get the consent on the 3 series. And the process is really approved by the Education Board and known to the principals, and our VPD team goes to school to do the vaccine, and the health nurse, the school health nurse is also aware, so that she knows in her school this time there will be a vaccine clinic.
Brian?
Okay, thank you for that response. My concern is that, some students may fall through the cracks, so to speak. And because if the notice goes home, the consent notice or request for consent notice goes home with the student, I know from past experience, sometimes those notes get stuffed into a backpack and they're not found till, say, spring cleaning. And the parent never sees the consent request, and the student continues to miss out on much needed vaccinations. So I guess it's an overarching concern that there are some students falling through the cracks because of the upheaval caused by the COVID vaccines.
Through you, Madam Chair, we also have a process to ask all the class, before the day of the vaccine, there is a reminder and a letter goes to parents. But in addition to that, we ask every student. So it's like the whole class, we take the class to the gym, and then they will have the vaccine and ask them. So if there is any issue about the consent or missed consent, there was some incident like that, and we find, for example, a high school student provide consent, but we don't have the parent consent. So we do this kind of reconciliation on the spot.
Very good. Thank you.
Thank you.
Okay, anything further? All right, I need a motion to approve the correspondence and news releases as presented. Luke moves and Helen Claire second. All in favor? That is carried. And Dr. Era, you have a comment?
Thank you, Madam Chair. There is another aspect of, just to add to what Dr. Zayed mentioned, under the Immunization of School Pupils Act in Ontario, all students under 18 who are registered in school must be immunized for certain vaccines, not all vaccines. So that's, again, another mechanism where the essential vaccines that can affect the public, whether it's measles or rubella, universally, everybody's vaccinated or had provided an exemption under that act.
Thank you for that. All right, item 8 is a staff presentation. 8.1, environmental health, and we have Andrew Barton. Welcome, Andrew.
Very much. Good morning, everyone. Can I just ask, Mary, will you be doing the slides, or do you want me to do that from here?
I can do the slides, Andy.
Okay, perfect. Thank you. Okay, yeah, so today we're going to be looking at the environmental health program update. And if we can move to slide number 2. I think that's the last slide there, Mary. There we go. So yeah, the presentation will include a brief overview on food safety, safe recreational water, drinking water, rabies, healthy environments, and vector-borne disease. If we move to slide 3, we can see that our team includes 12 public health inspectors, PHIs, 2 PAs, and in 22 at least we have 3 additional summer students, so 1 practicum student, and that is a PHI who is almost ready to challenge the boards to become a certified PHI, but needs a very sort of defined process to go through. So Gregory's Health Unit is one of the health units that supports that educational process. And an additional 2 summer students that really support us with some of our seasonal programs that we'll get to a little bit later on. What we're not going to be looking at today is the work of our tobacco enforcement team. We have another 3 TEOs working under my umbrella, but obviously time and the amount of content we need to get to means we can perhaps do that another time. So slide 4 shows, obviously, as you'd expect, last couple of years, our work has been atypical with a focus on responding to the pandemic as well as our continuity of operations, so our essential services. I did just want to spend a few seconds, though, to put up the numbers here for our environmental health helpline, because I think it quite neatly demonstrates that sort of transition back to the response phase, to the recovery phase. So in January, a total of 511 calls, of which 439 were about COVID. And by March, the calls had dropped to 226, of which about 116 were COVID. So very different proportions. And what's happened since March, of course, is we move into the summer season, which is very busy for us. And it's starting to be, I'm not going to quite call it normal yet, but certainly we've seen that normal ramp up of a lot of our seasonal businesses and seasonal activities. So if we go to the next slide. I'll start with food safety, and the order I'm presenting these in is broadly in keeping with the amount of staff time that these programs take. So starting with the most significant one. Program goal for food safety is to prevent or reduce the burden of foodborne illness. And one of our big components there is routine inspections. So inspection frequencies are based on risk assessment, and we have highs, moderates, lows, and ultra lows, with the highs being inspected the most frequent at 3 times a year. Inspections take part in about 1,600 premises in Grey Bruce, and 121 of those are with the ID team. I should just note that there are PHIs working in the infectious disease team as well. But yeah, 1,600 premises in total. Interestingly, that's actually up more than 10% since pre-pandemic levels. We all know that businesses suffered and in fact some unfortunately disappeared during the pandemic, but it's interesting to note that overall we have quite a significant increase, many of which are home-based businesses. So well, what do we do with these inspections? So our focus really is on HACCP, so looking at those critical control points, and that might be things like the kill stage, the cup temperatures, and then also things like storage temperatures, that sort of thing, prevention of cross-contamination, food handling in its broad term, and also certification of food handlers, and then of course structure and conditions. And although the frequency of the inspections are governed by the standards and protocols, the conditions themselves are actually governed by the regulations that are under the HPPA. So as well as inspections, we of course do complaint response. We don't get masses of complaints, luckily. So we were looking there at 2019, the last kind of, I'll refer to 2019 quite a bit through the presentation as our sort of last normal year. And I think it gives a better overview of the sort of typical things that we would do. So in 2019, we had 47 food premises complaints and 17 food product complaints. That's probably a pretty typical year. There is, I should mention as well, in terms of all of our inspections, not just food, most of our regulators inspections at least are encapsulated by a disclosure system, so the public can go online and see the results of those inspections. Okay, if we move to the next slide. So also within food safety, of course, there's lots of other non-inspection work. We do food handler certification. We have not yet restarted this, but we do face-to-face training for people who find that to be best, perhaps for various equity reasons. A bulk of the certified food training is done online these days, but certainly it is quite nice to still have that option. We support federal and provincial partners, of course, with food recalls, typically not a big component of the program until something like the maple leaf recall from a few years ago happens, and then it becomes really the main component of the team for a period of time. Menu labeling, this is a completely separate act and regulation, really helps to support public making healthy food choices. And this is there's a limited number of premises. These are the sort of the bigger chains and things that you'll see have to have a certain amount of nutrition information on their menus. And then of course public promotion and education as well. So the next slide, please. So safe recreational water, big issue in Grey Bruce, of course. Program goal is to prevent and reduce the burden of waterborne illness and injuries. So the injury component is here as well. Inspections again are a component here, and we have inspections of swimming pools, Class A and Class B, Class C facilities, which is this sort of catch-all for things like wading pools and spray pads, public spas, what most people perhaps would call a hot tub, but the regulations call spas. In terms of numbers, we're looking there, and again in 2019, 461 inspections and then 15 re-inspections. The inspections themselves look at a number of issues to do with both those issues, both safety and the infectious disease side. So that is safety equipment, the actual pool equipment itself, the pool chemistry, we do the actual checks of the water and so on, structural conditions. And again, we're looking, of course, as well at essentially the work done by the operators to make sure that they are running those facilities correctly. Some of these facilities are actually quite complex to run. We have some facilities in Grey Bruce that are unusual in their design, quite complex, and so those certainly they're not quick inspections. How often? Well, quarterly while open. So although 476 in some cases will be 4 inspections of a year of the same premise if it's open all year Beaches. So we have 12 designated beaches throughout Growing Bruce. There's obviously many more places where people can access surface water. With those, we do an annual environmental survey, and then it's a monthly testing program where one of our summer students goes in and they take individual samples, a minimum of 5, and they take a geometric mean, basically to ensure that the water is of a good standard there. The other components there as well, complaint response and promotion and education. As with all of our programs, we do, obviously like the public to be aware of what the risks are. Next slide, please. So safe drinking water. There's a number of aspects to this. So certainly people's own private drinking water, but also the regulated side of things. And obviously that changed significantly after the events in Walkerton more than 2 decades ago now. So the water systems have been divided into 2 categories, essentially. Those that are called large water systems, regulated by 170 by the Ministry of Environment, and what's called small drinking water systems, regulated by 319, and that's a health unit responsibility. The large and small is a bit of a misnomer. Some of the largest 319 systems are actually as large as some of the small municipally operated systems, but it does at least help define who has responsibility. So when it comes to 319 systems, responsibility lies with the health unit. We have routine inspections, although they are infrequent for water systems. And those, we use a ministry-provided risk assessment tool, risk categorization tool. We inspect the visual inspection, look at the water source, the treatment train, the distribution, and again, lots of conversation around the training of the operators and make sure that they are running those systems the way they need to be. In between those inspections, as they are fairly infrequent, we also have additional compliance checks to make sure that those facilities are doing the laboratory checks that they need to on the drinking water itself. When it comes to 170 systems, we don't regulate them. They're regulated by Ministry of Environment, but we do support the process. So we receive all the inspection reports that they do. And we are also involved when it comes to adverse water quality incidents, which is the next item down there. 151 of those in 2019. Some of those are for our own systems, but some are for the MOE systems. The reason we're involved is essentially to have a second agency just kind of looking at the process. We don't typically ask for additional work to be done in between the work of the operators and our colleagues at the MOE. Typically, everything has been done as it needs to be, but we have the regulatory responsibility and the power to be able to add additional requirements if necessary. Moving on to private drinking water support, obviously the Public Health Ontario labs are the ones that actually do the water testing, but we are involved with helping to look after the sites for water bottle pickup and drop off, and also giving advice to the public. So typically this would be where a member of the public has taken a sample, had an adverse result, and has phoned in. And this forms actually one of the larger components. Is about the second most common reason somebody would call our team, and we can help them through. Sometimes it's a very quick conversation, they essentially understand, but sometimes it really is a one-on-one education of what they need to make sure that their system is safe for their family. And then again, promotion and education, primarily around private drinking water testing, particularly in the spring, but we may have some other media releases, perhaps for something like a harmful algae bloom, which we'll get to with a later program. So next slide, please. Rabies. You'd probably be aware that rabies is a disease that was more common in the wildlife of grey bruce a few years ago than it is now. Ministry of Natural Resources has done an excellent job with their program of baiting to reduce the amount of illness in the vector species, but it's not entirely eliminated. And as a result, we have to do investigations when there has been animal exposures. And you'll see that the numbers there for the last few years. This is one of the things that continued to happen during the pandemic. This didn't really deviate. If a human does get rabies and it gets to the point where the virus, where the actual illness occurs, it's essentially 100% fatal. So it is entirely preventable, though. It's preventable through actions in terms of the investigation and also preventable through vaccine. So hence the program. Typically for those 550, 600 investigations a year, they will be with a domestic species, a dog or a cat, and it will result in a 10-day confinement to ensure that the animal is alive and well at the end of the days, those 10 days, which means that it wasn't able to transmit the virus during actually the incident itself. Occasionally, though, we move on to other things that are required. The Ontario Association of Vet Technicians and CFIA, between them and the health units, have a robust process in place for testing. So if an animal does pass away or has to be euthanized for some other reason during that period of time, then their brain material can be tested to ensure that they didn't pass away from rabies or have rabies. And that's actually just one part of the collaboration with various other groups. We've also got collaboration with local vet organizations and also One Health. Promotion and education when it comes to rabies is on two fronts, really. One, to try and get people to perhaps reduce their risky behaviors. So we do find a certain number of people each year will go and have interactions with the wildlife out there, which they maybe shouldn't. And as a result, perhaps not surprising, if you pick up a wild raccoon, it's going to bite you. So there's sometimes investigations for those types of things. And finally, in terms of working internally with our vaccine preventable disease team, is vaccine distribution. So this is where a physician, something's happened, we haven't been able to go through the other processes. A physician requires vaccine, and typically that will be distributed and they will simply follow the provincial protocol. But occasionally that might need to go to either the MOH or the vaccine team for further discussion. Okay, next slide, please. So healthy environments, left this to last because it probably is our lowest time in terms of FTE, but it's a very broad program. So again, program goal, reduce exposures to health hazards and promote the development of healthy built and natural environments. It's very broad. We have lots of collaboration internally with the health equity team, with foundational standards through a matrix management process. Externally, Ministry of Environment, municipalities, counties, conservation authorities, a bunch of other people. And I mentioned particularly their climate change, obviously hugely important. And I think we're just really starting to get to grips with how important a process that is. And that's actually been identified for our priority matrix project for this year. Part of the work there is certainly collaborating with other groups. We also provide planning comments for municipalities and counties, looking at that as one of the lenses. So health environment education as well. We are often pulled into just general sort of health hazard complaints or situations. These can be really broad. So it could be around housing standards, and we work proactively with people like Rent Safe on those, Canadian Partnership for Children's Health and Environment, also involved with housing standards and things. We get involved with specific issues. So it might be working with partners on spills, sewage bypasses. It might be something like noxious weeds or harmful algae blooms, which loops us back there to the impacts on drinking water. And then finally, we have sort of true health hazard prevention. So we do have an inspection component of this program as well. Routine inspections for recreational camps, children's camps, inspections upon request, so things like boarding and lodging homes, and inspections in other facilities that serve vulnerable populations. So we do annual inspections of arenas and the international agricultural workers, as the term now is. So we have 138 facilities there where inspections are requested. And I went in a little bit wrong order there, but also the complaint investigation at the end. Next slide, please. So the vector-borne disease program, it's an integrated management plan. Essentially what we're looking at here is a vector surveillance. What's happening out there in terms of mosquitoes, of ticks, of these things that we know can spread disease. We know that climate change is having a significant impact on this. We're seeing this northerly migration of things that we typically have not seen in Ontario before. So vector surveillance, non-human host surveillance, human surveillance, and then public education. And there would be vector control programs that potentially if required as well. For mosquito surveillance, you can see we're currently running about 85 traps. So what we do is we're trapping not super frequently, but on a sort of monthly basis throughout all of the municipalities. We're really at that stage of trying to have a really good picture of what's happening throughout Grey Bruce. Tick surveillance, that's program changed a little bit last year as the National Microbiological Lab stopped accepting ticks for testing that weren't found on a human host. But nevertheless, we still will be doing our active surveillance, so tick dragging, and in terms of the public service that's available, we are advertising a program called eTick, which means that people can sort of take a photograph and send that in, and they'll very quickly receive response as to whether or not it is a black-legged tick or perhaps something like a dog tick. We're specifically interested in black-legged tick because that is the vector spreading Lyme disease. And we've seen a significant increase over the last few years. Perhaps 10 years ago, we really didn't see very many of them. And now I don't think it's an exaggeration to say it's the most common tick that we see in Grey Bruce. And as of a couple of years ago, as I think you know, we did have our first high-risk area on the Huron coast there, which means that we do know we've got a population of black-legged ticks that is there and thriving and capable of transmitting the virus. So that brings me essentially to my last slide. I'm more than happy to answer any questions.
Okay, thank you, Andrew. Good presentation. So anyone have any questions, comments? Helen Clare, and then Brian Millen.
Thank you, Madam Chair. I have a few questions, if I may, for Andrew. The first is just to hear where the pickup drop-off site is for private water wells. I'm aware that during COVID, there were various places, but I wondered if those places were still open or if there was a centralized spot or several spots. And if Andrew could speak to that, that's my first question.
Andrew?
Absolutely, yeah. So, yes, you phrased that very well. We had for years had a network based in the hospitals as well as our own office for drop-off points. That changed at the start of the pandemic. We were, and I really would like to note how thankful we were that grocery stores in Kincardine, Walkerton and Markdale stepped up to offer us a temporary location to house those fridges and signage. I don't know whether they knew they were signing up for 2 years, but they've continued to offer that service for us, which is obviously helpful. We have started the process of returning to I'm going to call it a pre-pandemic service. One of the things we've learned during the pandemic, though, is that the hospital corporations have advanced their IPAC, their infection control processes, and the drop-off points will not be going back to the hospitals as a whole. So currently what's happening, and there's been quite a bit of conversation actually this week with various municipalities. So we are hoping to essentially have a similar number of drop-offs that we had prior to the pandemic, but the locations will be, again, in similar places, but we're looking to hopefully have them in municipal buildings rather than in the hospitals in those communities.
If I may continue then, Madam Chair, just to follow up on that topic. So Andrew, if I'm understanding, it's not yet established where the drop-offs are going to be, but that will be something and hopefully will then be publicized. Okay,
Yes.
Thank you. I'll move to my second question, which is to do with the noxious weeds presentation. Your whole presentation was really amazing. So I'll just say that. I'm just wondering, public health does look into private wells on private property. So this leads me to wonder about private ponds. Ponds and water bodies on private property. Are individuals able to call for an inspection or to take a sample or something like that to see whether or not there are noxious weeds or this blue-green algae on private ponds?
So I'm going to say the answer really is no, but I sort of soften that slightly by saying we'd certainly always be willing to work with any member of the public and sort of help them through a problem that they might have. The Public Health Ontario Labs does not have the ability to test for blue-green algae or in fact other things that you might have in surface water. So that's actually done through a different lab service, the Ministry of Environment. So when it comes to testing, that would have to be done through the Ministry of Environment for that particular issue. We would, however, obviously talk to any individuals and help them sort of understand what might be going on and sort of point them in the direction of other partners that might be able to give them further support.
Thank you, Madam Chair. The final topic is on rabies. I'm understanding that it's 100% fatal once it's embedded in the host human. And so there's a timeline between when somebody gets bitten and when they receive treatment, and that timeline obviously is urgent. So I have two questions for this file. One is, what is that timeline, since it's so crucial?
Okay, so the virus actually moves throughout the body in the central nervous system rather than the bloodstream. So in a way, it's one of the few things about the disease that's actually on our side, because it means it's a relatively slow movement. So you'll notice from the way that we manage the disease, generally, we don't go straight to vaccination. And that's because we actually have quite a bit of time from an incident, particularly if it's a bite to, the foot or the leg or something that's fairly common. Even the hand, although there's more nerve systems in the hand, but it's still quite a long way away from the brain, which is essentially where the issue is. So we have some time typically to start to do the 10-day observation period, to do a little bit of investigation. If then it does need to go to the vaccination is extremely effective. It is unfortunately not a simple process to go through. So there are, first of all, they are the vials of RIG that are given in and around the location of the wound, and the number of those vials that's given is based on the weight of the patient. So that can be potentially quite a large amount of injections. And then it's a series of 4 vaccinations after that. So it's not a minor thing, but it has a very good outcome. So it is an excellent backstop to have.
So my final question on this file was about vaccinations. Andrew, I'm hearing that there are prophylactic vaccinations. How effective are they to act against disease? I'm not sure if that's your response or if that should be Dr. Ara, but I would appreciate any response to that. Thank you.
I might give a semi-answer and then let Dr. Ara jump in if I can. So we're talking specifically about rabies. It's effective, and part of the reason it's effective is it reduces the what then has to be done if there is a bite. So the pre-exposure is often given most typically because of occupation, so people working regularly with animals, but also some people that travel to rabies endemic areas. There are parts of the world where rabies is still a significant burden of human fatality. The numbers are still quite high in some countries, so there is a travel element there. If then somebody does get bitten, one or two things can happen. They can actually do the teachers make sure that there is still protection being given, and or if it's within a few years, I believe it's 3 years, it reduces the amount of vaccine that individual has to have. In terms of the more medical side, I will leave it at that because I'm probably not qualified to go beyond that response.
Dr. Eric?
Thank you, Madam Chair. Through you, if I can address both last questions together, they can be summed or they could be correlated in a way. I echo everything Andrew mentioned related to the timeline when the vaccine needs to be given. It's very variable, and there are many factors that come into it, and that's where there are two risk assessments actually. One risk assessment includes two components, one of the patient, one of the animal, and the type of bite that was. The location of the bite dictates the urgency of the vaccine. If the bite is to the face, right close to the brain, that person needs the vaccine more likely very quick. If they had the vaccination beforehand, that is very reassuring because there is immunity in the body. On the other hand, if somebody had a bite in circumstances that are suspicious, where the animal was agitated or indications that the animal was not captured after testing was not happened, the incubation period for rabies could be very lengthy, could be months. There are documentation of over a year. So somebody who experienced a bite 6 months ago and did not have rabies, but the circumstances are suspicious, I would recommend the rabies vaccine as well. So again, there is huge variability. That's one of the questions that require actually an assessment to be answered. The second question or the second part of the subject is exactly like what Andrew mentioned. Pre-exposure vaccination usually is recommended based on occupation or likelihood of being exposed to the disease, whether it's vets or people who handle animals or do research. There is a list of these individuals. For the regular individual, common citizen, it's usually not indicated. And that is exactly related to what Andrew mentioned, that there's no urgency. There's a window of time of days to give the vaccine. So that's in general what I can add to what Andrew mentioned.
Thank you so much, both of you.
Brian Millen.
Thank you very much, Madam Chair. Andrew, I'm just wondering the topic of food trucks and or mobile food places. What is the process around inspecting them, and how is the public or how can the public know if they step up to a food truck that the place has been inspected and is safe? I've had a number of questions around that last summer, and I anticipate going forward it's going to be the same this summer. So if you could help me out with that, I'd greatly appreciate it. Thank you.
Yeah, absolutely. So food trucks, I mean, they're food premises, so they require inspection. The trick with them, of course, is if they're a true food truck, then they're mobile, and obviously that presents some difficulties. So we have food trucks. We have plenty based in Grey Bruce. For those, we have essentially a sort of home address, and that's what we would link them to that in our own system. And they would be inspected by the PHI that covers that area. We also might have food trucks come in from other areas, and this is particularly what we might see in special events. So we don't inspect every food premise at every special event. We just simply don't have the resources to do that. What we do have is a risk assessment process where we look at them, and we will have people go out to the larger special events. and we will inspect that as an event. So essentially the mobile premises there are almost getting a second inspection. So I know some operators of mobile premises will perhaps somewhat jokingly, but there's a truth to it, say that they are in fact the most inspected premises in the province, because they meet that sort of issue in a lot of different areas. And if they are active and they visit a lot of larger events throughout the province, then as well as being inspected by their home health unit, then they will have periodic inspections at events as well.
Thank you. And in regards to my question about how does the person know stepping up to the truck, is there any kind of posting that shows that the truck has been inspected?
Yeah, that is a little bit more tricky, I think. So our disclosure system is based really off the name and address. So if you're looking at a certain restaurant, you know where it is, you know what it's called. So the disclosure system works pretty easily. For mobile premises, we use the disclosure system in the same way, but obviously the address has changed. So the name will still work for you, assuming it's based in Grey Bruce. If that same truck is based in Simcoe, then you would have to know to go and look at Simcoe's disclosure system to go and see their most recent inspection report.
Very good. Thank you so much.
Okay, other questions, comments? Luke?
Yeah, thank you, Madam Chair. Just a quick follow-up on Helen Clare's question about the water sample collection and the locations. I just wondered, do you have a timeline on when that will be resolved, or when you expect to resolve that location by location? It's a matter of some concern in my own community, and a lot of folks eager to know when they'll be able to drop samples off more locally again. So any sense of that, Andrew?
I guess a general sense rather than an exact date. So those conversations are ongoing now with the municipalities. I've not had anybody give a sort of overall negative answer yet. I think the municipalities are all keen to obviously support their residents. So the questions at the moment are more about logistics. What does it mean? How much space? What sort of impact it might be on the municipal staff in terms of expectations? So I'm hoping that we can have most of that cleared up within the next couple of weeks. Public Health Ontario is already on board in terms of changing the courier route a little bit. So I would anticipate that certainly by midsummer, hopefully a little before that, we should be fully up and running.
Well, that's great. Thanks very much.
Okay, Andrew, I have one question. You mentioned food handler training and you said online. Is there a fee, and how often is that completed?
So there is a fee. I can't remember exactly what the fee is for the online course. It's fairly inexpensive. It's not intended to be a barrier in any way. And it's available at all times. And it's also available in such a way that if you're only able to spend, a half hour a day, or maybe you want to do it in a whole block, then that is all possible. And then of course you challenge the test, and pass rate's pretty good, and away people go. Our own course is a little bit more restricted, I guess. As I say, we didn't run that at all during the pandemic. It was one of the things that we weren't able to support. Fully intending on getting back to doing it, but obviously we do have to prioritize some of the other regulated work first. And it will be a set time, and we will do a sort of face-to-face presentation, and often actually work with local groups, maybe Chamber of Commerce or something, to work in a certain area. So we can be a little bit flexible there, but it will be at a defined time and place. And again, our cost is low. It really just covers the materials that we give out, and we give a thermometer with the course and that kind of thing.
So when you have this pass, or you receive the certificate, is it like good forever, or every 5 years, or 2 years?
I think it's recommended every 3 years. Maybe wrong on that, but it is recommended that there's a recertification process there. And one of the changes to the regulation actually just fairly recently was that premises are required now to have a certified food handler in the premises at all times. That was not the case before, and it's certainly we've seen a uptick in the demand for those courses.
Very good, thank you. Any further questions or comments? I don't see any, so thank you very much, Andrew. Always appreciate more insight into the programs that public health provides. So well done. Thank you.
Thank you. Thank you all for your time.
All right, moving on. Item 9 on the agenda is the Medical Officer of Health update, and Dr. Era.
Thank you, Madam Chair. I'll share my screen with your permission. So before my update, Madam Chair, has two components. One of them is verbal on the COVID situation, and I'll start with that. Just trying to unshare my screen. The COVID situation remains stable, and all the indicators that we observe are heading in the right direction. Number of cases, although it's just a proxy, is around 10 new cases per day, quite manageable, and reflects to a certain degree what would happen in the healthcare or the high-risk setting, but could be a proxy for the community transmission as well. Hospitalization is down, ICU is negligible. The number of outbreaks is also down. I believe 3 long-term care outbreaks at this point. Number of deaths, there has been a number of deaths, but looking at the number of, the indicator itself is slowing down, but even when it was high since January, looking at every case, it's a premature death. It's not a death that would have happened just because of COVID, somebody third stage disease, cancer, or end of life, and they happen to have COVID. Most often than not, that is the situation. So all in all, we were heading into the recovery, or continue to be in the recovery. We will continue to monitor as well. There are certain speculations that in the fall we might have a wave. In all cases, we have the system for it, and at this point, it is heading in the right direction. And the second part of my update, Madam Chair, is a briefing on the new virus circulating around the world, human monkeypox virus. And my slides are around 10, just in general description of the situation. The virus itself is a zoonotic viral disease. Zoonotic more or less is a virus that has a reservoir in the environment within animals, whether it's a Lyme disease within a tick or with a rabies, the virus, the reservoir would be a fox, raccoon. In this case, it's a zoonotic, and it was discovered in 1958 in 2 outbreaks related to monkeys. Similar to, in its presentation, to the smallpox virus that threatened humanity for a long time, and vaccine eradicated it. Nevertheless, the vaccine actually worked for both viruses, so we might see some talk about it in the future. The monkeypox infection typically is mild. It's self-limiting. It's 2 weeks to 4 weeks, and the symptoms are not severe. However, there is a percentage of the people who are infected, it could be very serious disease, and the fatality rate is historically between 0 to 11 from data from World Health Organization. The more recent data is between 3 to 6% fatality, which is quite significant. Situation update: the human monkeypox is endemic and has been endemic in Africa, and it did not before cause infections outside of Africa. People who travel to Africa might have acquired it. In May 2020, this month, several number of clusters in different jurisdictions that are not endemic for the where the virus is not endemic were identified. A number of these jurisdictions reported clusters related to men who have sex with men, but not all outbreaks and not all individuals are. And as of May 26, yesterday, there were 26 cases confirmed in Canada. Surveillance of the data is expanding, and by the day there is new case definitions we received from Public Health Ontario. We received, I believe, last Friday, the first set, then it was updated. And usually these surveillance data will be sensitive, so they will capture more and more until the case definition is adjusted to serve different function. At this time, it is designed to be sensitive to capture more individual and even probable, even without confirmation. Symptoms, similar to many other viruses, there are systemic symptoms: fever, headache, anorexia, fatigue, loss of appetite, muscle pain, joint pain, these two last words, lymphadenopathy, lymph node swelling. And within 1 to 3 days of that period, there could be a typical rash, and the rash is quite significant, especially if it had involvement to, if the lesions had involvement to the eye or multiple locations of the body. Transmissions, the transmission is contact of secretions from the lesions or from secretions from the individuals that carry the virus, and even contact directly or contact through clothes or bedding, which would make it a bit more transmissible. An incubation period is about 14 days. It varies between 5 to 21 days, which is the period the person would have to observe their symptoms if they were exposed. And period of communicability, so long the person has lesions, they will be infectious. And that's a period of isolation for the individual who is a case. Case and contact management, again, we start by probable cases, and if there are confirmed cases, they will be managed through certain protocol. Contact management is another set of protocol. And for the probable cases and the confirmed cases, isolation is key. And there could be monitoring functions, active monitoring by the health unit, depending on the scenario and depending on the risk. And those, as we know from COVID, are very diverse protocols depending on the case and the situation, and we support our residents if they happen to be dealing with those with one of these categories. Actions taken provincially at this point: the Chief Medical Officer of Health issued an order under Section 77.6, and in general, there are reportable diseases where each healthcare provider must report to the Medical Officer of Health. And obviously, this disease is not on that list, so reporting is not going to be automatic. This order is a mechanism, a quicker mechanism to ensure reporting. The other activities on the province level: development of frequently asked question website, liaison with Public Health Agency of Canada, and as I mentioned, development of case definition and updating them from Public Health Ontario. There is a notice that went to emergency department, staffs. Again, that's just to ensure thorough understanding from different levels of the system of the importance of reporting about this disease. Action taken locally, as I mentioned, case and contact tracing, that's bread and butter for public health, and we will be refining it as the case, as the protocols from the province require us. Working with local healthcare providers, whether it's providing communication or providing education. We will be scheduling rounds with the hospital, and in an imminent future, we're working with a number of physicians there. Communication to partners and public health, and public, just to keep the public and the community informed, working with the provincial level and collaboration among other health units, neighboring and non-neighboring. Laboratory testing, Public Health Ontario Labs is mediating the testing. All the samples are sent to Manitoba at this point. The National Microbiology Lab is a very state-of-the-art and top-notch lab, and usually the testing starts there. Then each province would develop their own PCR testing or their own mechanism. So at this point, any physician or healthcare provider suspecting the disease will be contacting Public Health Ontario, contacting the health unit. We'll walk them through the testing, or the PHO usually walks them through the testing and how to send the samples. The turnover at this point is 2 days, 1 to 2 days, depending, and that is quite robust. Use of therapeutics. The disease, the main treatment is supportive, just supporting symptoms. There are certain indications for antiviral medication or vaccine immunoglobulin serum in certain indications, whether it's pregnancy or lower immunity. And there's a list of them, but we will receive more information from the province on the use of those drugs. I'm not aware if it started at this point or became available, but in general, the disease known to have those therapies or options. The vaccine, the same vaccine for smallpox and the monkeypox, human monkeypox virus. There is a vaccine that's authorized in Canada, and it is not reproductive. It's not replicating, it's live attenuated. Replicating vaccines means that the vaccine itself is a virus. It's a live virus, but it is weakened. So it's able to generate immunity without generating severe disease. And some of these vaccines are replicating in a way that the vaccinated person can infect other people with the vaccine. And there is indication for this, and there is contraindication if there is a pregnant individual in the house. It's not. The vaccine authorized in Canada is non-replicating, so that is a safer option of the vaccine. In the States, I believe they have both approved by CDC. NACI is planning to release its guidelines in a few days, in the beginning of June. And as usual, they would look at the benefit of the vaccine versus the risk or the adverse event. They would evaluate the risk of the disease itself, the prevalence in the community, what type of vaccine it's going to be. Is it going to be pre-exposure or post-exposure? Is it going to be for certain groups or for people who are exposed in or has high likelihood of exposure? All these are to be answered, but in general, and this slide is my own bias, for most people who have exposed to the virus, the risk of the disease is far greater than the risk of the vaccine itself. The vaccine, the disease, as I mentioned, fatal in 3 to 6% of the time, which is a significant percentage. The vaccine, most often than not, in a million, there is 1 or 2 people who would have severe complication leading to death. The rest of the million would have mild fever and similar symptoms to the disease itself, but way milder. And comprehensive assessment will certainly be part of determination by NACI and their recommendation. I included the references as well if people would like to read a bit more about it, and open to questions as always, Madam Chair.
Okay, thanks, Dr. Era. Questions or comments? Helen Claire?
Thank you, Madam Chair. Through you, I have several, if that's okay. Dr. Ara's presentation showed that it's mild, mostly mild and self-limiting, but it could present severe illness in some individuals with 3 to 6% fatality. I'm wondering if there is already known a class of those individuals. Are they seniors? Are they people with compromised health, underlying health conditions? Do we have any idea of what class of people would make up that 3 to 6% that are more at danger of fatality?
Through you, Madam Chair, definitely any condition that would lower immunity would be a candidate. Chemotherapy or cancer treatment, pregnancy is known to lower immunity, and there is those are the general ones. Age is a factor that leads to lower immunity. So again, that would be one of the variables there.
Thank you. Couple more questions. So is there, Dr. Ara, I saw a slide on this, but I wasn't able to get the answer, forgive me. Is there a vaccination on the horizon for monkeypox? Is it the same as smallpox? I was unclear on that.
Madam Chair, through you, the NACI will recommend the type of vaccination. So there is vaccine, there is stock in Canada for vaccine. I don't know if it's available. I believe verbally I heard the ministry ordered 500 doses, which is a small number. And usually it's recommended for exposure. At this point, I don't believe it will be available for the public. There are certain assessments that would reveal the groups that will be available for them. The authorized vaccine itself in Canada would work for both diseases, smallpox, which is not existent anymore, and the monkeypox.
Final question and then a follow-up comment, Madam Chair, through you. So this is similar to smallpox, and I'm understanding that the smallpox vaccination can confer some immunity. And I'm just wondering, since a class of people who may be part of the 3 to 6% would be seniors, some seniors, or maybe many seniors, may already have had the smallpox vaccination. Am I understanding then that the smallpox vaccination would confer immunity on seniors or anyone that has already had that smallpox vaccination?
Through you, Madam Chair, I would have to look into the specifics of this question. It's a very good question. I don't know knowledge. I don't know if Dr. Zaid is aware about the length of immunity that's provided by that vaccine. But if it's all right, I can find the answer and answer it later.
Thank you, Madam Chair. And through you, just a final comment with regard to Dr. Ara's presentation and the part in it that spoke about the risk group of men having sex with men. I recall that when AIDS first came out, everybody thought that this was just a homosexual disease. And I'm just very aware that those stigmas are so much on the horizon even today. Now, of course, we've seen historically that AIDS may initially have been spread in certain populations, but within a very short time, they become in the entire community. And so I just wanted to make sure that that was underscored, that this, no matter what these early trends appear to be, is something that is of concern to all of us in the larger community. Thank you for that time, Madam Chair.
Okay. Any other comments or questions?
If I may, Madam Chair, I echo what Helen Claire mentioned in her last comment. And I want to add that the disease itself, from the risk of transmission and the type of transmission, is not anticipated to be a burden on the healthcare system. It's not anticipated to be as large as a pandemic.
Right. Thank you. Luke?
Thank you, Madam Chair. I think Dr. Ara may have just answered my question. My overall, I didn't really get the sense from your presentation about just how worried we ought to be about this thing, but I think you may have just sort of given me a sense of it. It's a virus that's going to affect some people going forward, and perhaps for a long time, but not one that's going to be in any way debilitating for society. Is that what I'm gathering from, at least in your professional opinion, Dr. Hara?
Through you, Madam Chair, correct, precisely.
Okay, very good. All right, next on the agenda is 9.2, public health modernization. There is no update on that, no movement right now. So we'll move on to 9.3, and we have the opioid situation, and I have Dr. Zayed.
Through you, Madam Chair, for the opioid situation, I just want to update you on the last activity or work of the COMO work group for opioid and drug crisis. We, in this group where many health units were working together on having a provincial act from public health. So there was a new resolution to COMO that refer with reference also to the resolution that was presented by Grey Bruce Health Unit before, but there are some new update which is related to the priority for a provincial multi-sector response, and there are 9 priorities. And these priorities include the multi-sector task force, like asking for a creating of a multi-sector task force, expanding the harm reduction practices and programs, and enhance the prevention and sustainability of support, and also expand the collection of epidemiological data, expand access to treatment, address the cultural stigma, advocate and support federal government to decriminalize personal use and possession of substance, acknowledge and address the socioeconomic determinants of health, systemic racism, and the action on the intersection and action on risk factors for substance use, which include needs for more affordable supportive housing for people with who use drugs, and effort to further address poverty and unemployment and precarious employment. And the 9th priority is community leadership, consistent community leadership by people who use drugs, and by community organization, including engagement with local drug strategies. And in this resolution, it was also highlighting the local public health involvement specifically, and that local public health agencies are well positioned with additional resourcing to play an enhanced role in local planning, implementation, and coordination of the priority areas that I mentioned, the 9 priority areas. And also working on harm reduction, substance use prevention, mental health promotion, analysis, monitoring and reporting of data on opioid and other substance-related harms, health equity and anti-stigma initiatives, efforts towards healthy public policy related to substance use, including but not limited to decriminalization, and providing and mobilizing community leadership. So this resolution was submitted to the Alpha Executive Committee and sponsored by COMO to endorse it, and it is also it mentioned that Alpha endorses the 9 priorities for a provincial multi-sector response, and that Alpha urges the above-mentioned parties to collaborate on an effective, well-resourced, comprehensive multi-sectoral approach. This note also that the provincial priorities and areas of contribution by local health agencies be communicated to the Premier, Minister of Health, Associate Minister of Mental Health and Addiction, Attorney General, Minister of Municipal Affairs and Housing, Minister of Children, Community and Social Services, Chief Medical Officer of Health, Chief Executive Officer of Ontario Health, and CEO of Public Health Ontario. Hopefully this will have more emphasis on the provincial action and the creation of the task force at the provincial level, in addition to guiding the local public health activity or involvement with this problem. In addition to that, also we have more work at the local level, which has been really acknowledged by Public Health Ontario. So our work at mobile or community leadership, working with other partners at the local level, I have presented to Public Health Ontario, and it has been really acknowledged by them, and they will provide whatever help we need in terms of evaluation and publication, and going to have this as a consistent support for us, even with research as well.
Thank you, Dr. Zayed. Any comments or questions? Okay. I would expect that at some time decriminalization of small amounts of drugs will be a topic for discussion with this board, but we'll wait until things are moving on with that. And Dr. Zayed, I wanted to ask you, apologies, I did see your hand up at the last moment. Did you want to comment on the monkeypox?
Yes, I just want to say that the smallpox vaccine gives 85% of protectiveness for vaccine effectiveness for monkeypox. The other thing that I want to mention is about the vaccine that is used actually in the States. It was used in the outbreak in 2003, and the history of bringing monkeypox to the States, like it's the first time outside West Africa, it came with some wildlife market for some sort of rodents or mice that was connected to the prairie dogs, and the prairie dogs transmit the disease in 2003 to humans. So that was the first outbreak outside West Africa, and they used the vaccine at that time. So it is used in outbreaks, and it also has been used as a pre-exposure and has effectiveness of 85% as well. The outbreak right now, or the cases of clusters outside West Africa, is found in the Middle East, in Israel and UAE, in Argentina, Canada, USA, and European countries, so with some clusters. And the young men are the large proportion of cases. And there is a typical presentation, which is some sort of small vesicles or like very small vesicles. It's different than the large outburst of that disease in West Africa.
Okay, very good. Helen Claire.
Thank you, Madam Chair. Through you, my question was specific to the elder population that may be at risk for monkeypox, and that's why I was asking about the efficiency or the effectiveness of the vaccine. So I very much appreciate Dr. Ara's comments, but I wonder if she might be able to talk about whether or not an elder who has had the smallpox vaccination a long time ago, do we have any data on whether or not that elder might still be protected, or have those studies not been done? In other words, does the 85% have a time limit on conferring immunity? Thank you.
Dr. Zayed?
Through you, Madam Chair, there is some studies that mention that the immunity is a long life immunity, and it really have this 85% protection unless the person is really immune compromised, as Dr. Ara mentioned.
Thank you. Dr. Ara, did you want to comment?
Through you, Madam Chair, I was just gonna mention that we will look into if there is complete evidence on this. I realize Dr. Zaid just answered the question. In all cases, we'll look into it formally and we'll respond.
Thank you. Okay, so we need a mover and seconder to receive the MOH update as presented. Alan and Brian O'Leary, all in favor? That's carried. Thank you. Item 10 is other. 10.1 is the 2022 Board of Health orientation package. You'll remember this package was presented to the board once, but it was taken back and reviewed by the executive and is now being brought back to be finalized and then approved by this board. And I would ask that every member make sure they review this package. And you know what, it's pretty interesting when you start reading it. There's a lot of good information in there. So, and when you do review it, please send Mary an email stating that you have signed off, you've read it and reviewed it and understand it. And if you have questions, please bring them up at a board meeting. So are there any comments with this? Have you had a chance to look at it? And I think what the executive looked at it again, and we're confident we've covered everything. So if we're in agreement, I would like to see a motion on the floor that we have approved this package for 2022, the orientation package. So I need a mover and seconder. Alan and Helen Claire, all in favor? That's carried. Thank you. So yes, we'll look forward to you responding to Mary, and if you don't, we'll follow up. Item 10.2 is length of the county appointments to the Board of Health. Typically, they have been 1 year, but during COVID, they were we asked each county to extend it to 2 years because of continuity with COVID and just the efforts that would have been put in to train new board members, and there was too much happening at the health unit at that time. So Dr. Era, did you want to comment further on that?
Madam Chair, I just want to mention that when the emergency started, the board requested from the 2 counties to extend the membership for 2 years, and it's warranted now after the declaration of the emergency over to communicate back to the counties with a direction. So I'm looking for a direction from the board whether we need to go back to 1 year or have a discussion around or 2 years or any period of time that would allow for turnover that's appropriately balance the board continuity and new contribution.
Okay, good. Any comments on that? What's your thoughts? Alan?
Madam Chair, I would assume like most or both procedural bylaws with both Grey and Bruce counties, will have a time frame on them, won't they, for all the committees, whether they're annual or whether they could be changed to 2 year or whatever. But I would assume, as I say, that both procedural bylaws would have to be looked into.
Correct. Dr. Era?
Madam Chair, that's exactly the point. One of the 2 counties reached out to us to say, how would we recommend that the bylaw reflects the need of the board? So that's, again, an opportunity for us to provide that input.
Helen Claire?
Thank you, Madam Chair. Through you, it would seem to me, to still state the obvious, that we have an election coming up. So there is a certain amount of dynamism in this conversation. But second, I would suggest that we have some kind of a solution where we don't turn over all board members at once, so that the county might determine to change half of each contingent that we have on the board, just for the stability of the board, for the training, for the knowledge that this board has, so that new people can be brought in gradually. So that's what I would offer up as a suggestion. Thank you, Madam Chair.
Okay, there's some, if you think about it, we may not all get reelected, and the continuity would be the 2 provincial appointees, but Brian Millen.
Thank you, Madam Chair. And I hope your optimism isn't reflective of what's coming. But anyway, nonetheless, I'm wondering if we ask the counties to perhaps change the appointment length to the board to a 2-year term, or 2 years at a time at least, given the nature of what we've seen in the past and the importance of public health, the importance of being up to date on what's going on at the health unit. That would be something I wouldn't be adverse to supporting.
Okay. Alan?
Thanks, Madam Chair. I totally agree with Brian. I think it's always hard to sometimes agree with him, but anyway, in a case like this, I do think, I mean, that's obviously it's 4-year term. So this gives a member, half of the term to be on there. So I think 2 years is reasonable. Sometimes a 1-year term, you really don't get the full gist of what goes on at the committee, and then all of a sudden it's a new turnover. So I think that's an excellent recommendation.
Okay, thank you. Luke?
Yeah, thank you, Madam Chair. I think that it would be a good idea, at least from the perspective of Bruce County, to leave the matter in the hands of the county. Each county has its own approach to these things, and it will be affected by a number of other considerations, right? Committee appointments are, this is made as one of many committee appointments, and there'll be a certain shuffling of the deck, and there's a certain balance that has to be achieved. And you may find that a county council has difficulty maintaining a member for a 2-year period as a result of its own internal process. So I think that, and you'll see that no matter what we may suggest here, I'm living proof of the fact that it may not come to bear, right? That the county may choose to swap out its members at any time because it has the ability to do so. So I'm not really certain that any kind of direction from us is necessary. The counties, at least Bruce County, and I'm quite confident Grey County as well, know that consistency is important, and they know that it's important to have a longer term membership as much as possible. But it's also a body designed with political representation that can, as you pointed out, Madam Chair, turn over like that, right? So, and that's not an error. That's the design. That's how it was built. That's the intention. So, so it can happen, and it may happen at any time, and that's something we have to live with. But my suggestion would be let the counties decide what it works best in their systems, and we'll accept whom they send us and how. Thank you, Madam Chair.
Thanks, Luke. Brian O'Leary?
Thanks, Madam Chair. I would agree with Luke, but I would still send a recommendation, because I know that the counties they have the power to make that decision, but they're more than likely to go along with the recommendation as well. And if that's the way the board feels, we should send that recommendation. And if I could, I'll just throw this conversation a bit of a loop. I think we should be discussing attendance at these meetings as well. And something should be in place. And I say that with extreme sensitivity towards a mayor's schedule. I know as a deputy mayor, my schedule doesn't even come close to a mayor. But that being said, Madam Chair, you're a mayor and you're here every meeting. And to me, it's simple. Friday morning, May 27th, between 10 and at least 1, do not book anything for me. I'll be at the Board of Health meeting. And I don't understand why there's a problem there. And I think if there is a problem, then should we be having a conversation about having an alternate board member at the same time as the conversation as we're having? I'm just throwing that out there.
Okay, Helen Claire, then Alan.
Thank you, Madam Chair. Through you, in the orientation package and indeed in our policies that we have gone through, it does address a requirement for attendance. And there is also, if memory serves me, an opportunity for the board to suggest to the counties what is required, rather, to educate the counties what is required of this position, so that they might consider the time commitment and the skill set, the competencies that would best serve on the board. This is the points that my colleague Luke made are very well made, but I respectfully suggest that this is public health for the entire region, for 2 counties. This must be at the top of the list. It requires a commitment from every single member around the table to their highest and best, not just in attendance, but to commit to stay apprised of all the documents, of the education that's available to us, so that when we come together around the board, that we are truly, our decisions are more than the sum of their parts. We can't do that if we are not committed to that. And some people at the county level, if they don't know what is required, they can't be expected to be able to make good decisions as to whether or not their contributions would be best committed to a health board as opposed to a library board or some other board. This is a really needs to be a high demand portfolio and something that is given the most serious consideration. So while the final decisions do rest with the Grey County and Bruce County, if they have reached out to the board for suggestions, I strongly urge the board to give our best suggestions on all of these things that my colleague, Mr. O'Leary, has just raised about attendance, and which is, we have a foundation piece in the policies and orientation. I mean, if people don't read that, then they can't come to the table with what we need. And those that are reading it are trying to carry the weight. And we're not serving our community unless we do our best. Thank you, Madam Chair.
Okay, Alan?
Oh, thanks, Madam Chair. And to Brian O'Leary's point, the executive committee spent considerable time on that topic, as Helen Clare has alluded to, trying to get the right wording on it. And hopefully we have it in the procedures. But as I say, I don't want to reiterate what everybody else has said, but it's definitely a component attendance on this committee that if you're not attending, you're falling behind on it and you're not doing good representation from the body that you're supposed to be here for. So, and there are provisions in there where the chair can step in as well and address to either the provincial appointee or body or to the counties and regarding representation. So we hope we've got it covered, but it is an excellent point to have brought forward.
Okay. Luke?
Just on that point, Madam Chair, since it exists in the policies and we have policies around it, I think it would make sense to simply send those policies to the counties and ask them to convey the board's policies to members of the county councils. I think that we have those policies, so share them, and we don't need to do any more than that, I don't think.
Okay, so, and I've heard that it's recommended that we advise the both counties that we would emphasize that a 2-year term would be better than a 1-year term, but just put the emphasis on what's involved, the continuity, the education, what it takes to get up to speed on this board. So, and I know come when the election, right, that's when the committees will be chosen. So if we could have a letter stating at that time, along with the description of what's involved, would help. Alan?
Madam Chair, would you prefer it be a motion from the board, or what procedurally would be our best approach then to send that information to the counties?
Well, I think either or. The motion would show how serious we are about having, educated, up-to-date board members. It's how strong do you want to send the letter to be?
I think Member O'Leary, had a good point saying, to send that through if it's a recommendation. So my suggestion would be, let's make it a motion. And I certainly would be prepared to move the motion that the recommendation from Board of Health is that the commitment be to the counties, that it be a 2-year term. And then also send that excerpt from the our policies showing that the commitment that they need to observe whenever they are wanting to get on that committee.
And then at that time, either county will make their own decision, whether it's a 1-year or 2-year.
Right.
Luke?
Thank you, Madam Chair. Not to quibble with you, Madam Chair, but the suggestion that if we were to appoint for a 1-year term, that the member wouldn't be educated or up to date, I think is not fair, right? I mean, this board has had 1-year term appointments for up till the pandemic for a very long time, right? And those members were good members, I think. I always felt well represented by the representation on the board. So I think it's unfair to say to the county, because Bruce County, I think, may choose to only send members for 1 year. And I think it's unfair to say that because the county has chosen to do that, that it's sending members who aren't good or who aren't educated or up to date. We can have good members there for 1 year. I just hate for the board to send that message and to diminish the appointees that we may receive for 1 year. And if we prefer 2-year members, that's fine. But I think a 1-year appointee can be a good appointee too. Thank you, Madam Chair.
I agree, Luke, and apologies if it came across that way. But what the executive is trying to say is that there is a lot of information here, and we're all trying to represent Grey and Bruce to the best of our abilities, and COVID has emphasized everything that's happening. So, and I agree, we've had some excellent members on this board, and you don't know until you get on this board what's involved. So I know people put a lot of time in and effort. So okay, we have a decision. Do we want to have a motion or do we want to send a letter? Alan has said he's willing to move that motion, that the board would prefer a 2-year term. But if the county doesn't, then that's fine. Brian O'Leary, you want to second?
I would be happy to second that. Thank you.
Okay, and Brian Millen, you were going to comment or second? Okay. So it's been moved by Alan, seconded by Brian O'Leary. And Alan, will you just repeat what you suggested for the motion?
That the Board of Health members recommend to both Grey and Bruce counties that the representation for board members be a 2-year term.
Okay. Any other, we've got a mover and seconder, any discussion? Helen Claire?
Yes, Madam Chair, thank you. Through you, just wondering if we can't change that wording so that the emphasis is on succession planning for the board, and doesn't sound like we're saying something about the contributions of people for 1 year. So that also would allow some flexibility at the county level. So if we were to say that we are requesting, the Board of Health suggests no more than 50% of the county's appointees be replaced after 1 year. And if we say that's a suggestion that no more than, that allows the county to determine whether they're going to replace all, or whether it's a 2-year term, or whether it's a 1-year term. And that allows the flexibility and also makes our point that we're trying to hold on to the knowledge that we have around this table. Thank you, Madam Chair.
Okay, Alan?
I respect Helen Claire's comments, but I mean, we've all been through that political part. I mean, no one knows what's going to happen with the election. I mean, it could happen, and not likely, but it could happen that no members are returned to either county council. that it's an unforeseen thing, but it could happen. So by wording it that way, that no 50% or the note of 50% turnover wouldn't be able to be in effect anyway, because you wouldn't have that option. So I think, as I say, I think let's keep it simple. I'm just saying that we recommend to them that it be a 2-year term. And then, as I say, the counties can comment how they want on it.
Right. Helen Claire?
Yes, Madam Chair, the wording that I was suggesting was suggest. So that just would mean that that's what we would prefer. Obviously, if everybody around this table is not renewed in the municipal election, then we can't have that. But our ideal would be that we don't lose everybody around the table. That's not what we're trying to do. We're trying to keep the knowledge around the table that has been hard won by the members that have put the time in, coming to the meetings, reading the stuff, and contributing at a high level. So that's why I made the suggestion, but obviously I will go with whatever the board determines. Thank you, Madam Chair.
Okay, so we do have the motion on the floor. It's been moved and seconded. I'll ask the question. All in favor? So 1, 2, 3, 4. That's carried. Thank you. And of course, like we said, the counties will make that decision. So, all right. Item 10.3 is Board of Health self-evaluation. This is a reminder. We do have a policy, and this is to help board members fulfill their role and the tasks that are assigned as a board member. And it does improve effectiveness and engagement with all of our members. So there are no names or identifiers when this survey is completed, but it will be discussed at a board meeting, just some of the information that comes out of that self-evaluation, because we may be lacking in some areas and really good in other ones. So. Any comments, Helen Claire?
Thanks, Madam Chair. Did I miss that? Like, did we receive this?
No, it's coming.
Oh, okay.
Yeah.
Okay, great. Thank you.
Yeah. This is a reminder that Mary will send it out, and this is why we're doing it, right? And then we'll bring back the information and at a high level discuss it. Dr. Era?
Thank you, Madam Chair. Just specifics, the evaluation would have 2 components. One of them is for each individual to evaluate their own performance according to the criteria, then keep it with them. They don't send it back. It's just for knowledge, for measurement, or a tool to help the board member identify the strength and the room for improvement. The second one would be for the performance of the board in its totality. And the survey would not carry identifiers, so each person can fill it one time without entering their name, and will present the results in aggregate without any names.
Right. So that's coming. All right. Item 10.4 is, this is a letter that the Board of Health sent to Christine Elliott, the Minister of Health and Deputy Premier, and the Associate Minister of Mental Health and Addictions, Michael Thibodeau, if I'm pronouncing that correctly. It highlights our commitment to addressing mental health and addiction, and recommending a provincial task force. Dr. Zayed referred to that. So we're looking for a task force to be established, and that a Grey Bruce Board of Health member sit on that task force. So that's for information, just so you have the letter. And 10.5 is the Southwest Tobacco Control Area Network. This is a submission to the Legislative Review of the Tobacco and Vaping Products Act. Dr. Era, do you want to speak to that?
Thank you, Madam Chair. Yes, I would like to mention a brief summary, then I would turn it to Dr. Zayed with your permission. So this is an initiative that the Southwest Health Units contribute to. So our health unit is one of many, and it's one of the opportunities to improve the legislations controlling vaping and substance use, whether it's cannabis, vaping or tobacco to prevent initiation of vaping by youth, young adults, and non-smokers. And it touches base on many aspects of the control, whether it's regulation related to vaping product flavoring and additives, or the percentage of nicotine, or the on-screen TV impressions of smoking and vaping. And obviously the Healthy Net and the network recommends more restrictions on the multiple aspects of this issue. And with your permission, Madam Chair, I can turn it to Dr. Zayed.
Okay, Dr. Zayed.
Thank you, Dr. Through you, Madam Chair, I just will give some summary about this network, Southwest Tobacco Control Area Network. So Grey Goose Health Unit is one of the 7 partner units that comprise the Southwest Tobacco Control Area Network. Staff from each health unit within the network meet and collaborate to organize activities and initiatives related to tobacco and vapor prevention, protection, and cessation. Grey Goose Health Unit has been participating in a review and discussion that have formed the Southwest TCAN submission to the Tobacco Control Directorate of Health Canada on ways to strengthen the Tobacco and Vaping Products Act. This submission, which is being presented to the board member for the endorsement today, is part of a mandated 3-year review of the Act. The focus of the Southwest TCAN submission is on the vaping regulation section of the Act and their ability to protect young people from the harms of vapor products. So the recommendation to Health Canada include banning all vapor and e-product flavors, implementing a framework to strictly regulate the advertising of vapor product, and restricting the availability of high concentration vapor products. Actually, since this draft has been submitted, the federal government did respond to the activities and announced that they would be enacting a federal tax regime on vapor products effective October 2022. The agreement of the Southwest network is that the network won't be amending the submission, as it doesn't hurt for the government to receive reinforcement for action they have already taken. So the main idea here is to endorse this activity or the draft to Health Canada. There is also a Middlesex London Board of Health discussed it, and they submit a similar endorsement in mid-April.
Okay, thank you, Dr. Zayed. Any comments or questions? So for endorsement, we need a mover and seconder to endorse this to be the report to be sent to Health Canada. Moved by Brian Millen, seconded by Luke. All in favor? That's carried. Thank you. Okay, I know Kim is patiently waiting for us with the financials, the corporate services. Do you want to push through, or do you want a 5-minute break? I'm not seeing anything. Let's push through. Okay. 11.0 is corporate services, and the first quarter financial report is from Kim Rutherford. Kim?
Thank you. Through you, Madam Chair. This is the presentation of the first quarter financials for 2022. Year to date, March 31st, we had a surplus of $331,000, which is made up of various pieces. The main one is our mandatory programs. So we received enough ministry, county, and COVID extraordinary funding to cover all of our mandatory and COVID-19 vaccine costs in the first quarter. So as of the end of March, our funding and our expenses matched each other, and our mandatory and COVID was fully was fully funded. So the surplus that you're seeing at the end of March is from our separately funded programs such as Healthy Babies, the Children's Oral Health Initiative, and the Seniors Dental Program. Those programs have extraordinary surpluses that we don't usually see in them due to the staff in those program areas helping with the COVID response, and their corresponding wages and benefits being moved over to the COVID programs to reflect that time spent in them. So typically these programs are fully spent, so we won't see something like this going forward. But we did utilize the opportunity with the surplus to purchase some needed supplies and equipment and make some updates to some of the resources we have to favorably position these programs moving into their next fiscal year. So on our revenues, so year to date, our revenues are in line with budget with the exception of the COVID-19 extraordinary funding. So we required less COVID-19 funding. We needed to record less than we budgeted to cover our costs, but we do have access to additional COVID-19 funding if we require it. So we've been approved for more than what we've recorded to date. And MCCSS and Health Canada, they're in line with budget, but they operate on an April to March fiscal year. So March 31st is showing their full year financial results in these statements. On the expense side, our salaries and benefits are under budget by $676,000. Some of this is from the Seniors Dental, the Healthy Babies, and the co-high programs that had the surplus that I discussed earlier. And some of the other surplus is from less overtime than we expected at the start of the year, and a couple positions that we're currently recruiting for that are vacant. All of our operating expenses are under budget with the exception of telephone. From the capital statement side for the building capital, there was no major building repairs or maintenance completed in the first quarter, just the regular quarterly mortgage payment. For our capital projects, so that's our dental clinic renovation. So the Markdale one was completed in 2021. The Owen Sound Dental Clinic renovation started January 10th of this year. We were hoping to have it completed by the end of March. We did receive approval from the ministry to carry forward $30,000 of funding beyond the March 31st cutoff, which we ended up using. The cabinetry in the clinic space wasn't done by March 31st, so we will use the funding, the $30,000 to cover those costs past March 31st. And the good news is that we've got the clinic reopened now. So on May 16th, the clinic reopened to the public. And lastly, there's a overtime graph that I hope gives a visualization of the overtime trends that we've seen over the past 3 years. So 2022, we started out with quite a bit of overtime as we dealt with the Omicron variant, but since March, the overtime has dropped significantly as we are trying to resume normal operations and program planning. Thank you.
Thanks, Kim. Are there any questions for Kim with the financial report? Okay, I don't see any. I need a mover and seconder to receive the first quarter financial report for this year, January to March, as presented. I have Brian O'Leary and Brian Millen. All in favor? That's carried.
Just Madam Chair, quick question there, if I might, please.
Certainly.
Are we up to date on financial transfers from the ministry to the Grey Bruce Health Unit regarding COVID expenses? Because I know there was they promised to pay some expenses, and I'm not sure, did all of those commitments from the ministry come through, or have they? Please.
Kim?
For you, Madam Chair. So for 2021, yes, all the money has come through. For 2022, we have approvals for amounts, but we haven't actually received the cash flow of those approvals yet.
Very good. Thank you.
Okay, so I'll ask again, all in favor? That's carried. Thank you. All right, the next report, Kim, the 2022 funding announcement.
So this is the 2022 funding announcement update. On May 2nd, we received our 2022 funding package from the Ministry of Health. This is one of the earliest funding announcements we've had, and a lot of our requests from our budget were granted. So some of the highlights, the ministry provided increases to our mandatory program funding, as well as our seniors dental program. The seniors dental program expanded its eligibility in 2021, which is why additional base funding has been provided for that program. We were approved for 50% of our COVID-19 request and 80% of our COVID-19 vaccine request. In correspondence with the ministry, they've said that all health units were approved for a similar percent as to what we received of their COVID requests. And if we require additional funding, that should be evident in the quarterly reports that we submit to the ministry throughout the year. So if we are facing financial pressures or the amount of COVID funding approved is not covering our costs, then there is the opportunity to ask for the additional funds then. The Infection Prevention and Control Program, or the IPAC Hub program, it was approved again in 2022, as well as the School Focused Nurse Initiatives. So those are both 100% funded by the Ministry of Health. And we didn't have to put in any request for those. The ministry has just granted continuation of those programs for this year. We did submit some additional one-time requests with our budget they were all approved, and the ministry has approved them at 100%. So the requests approved were the Public Health Inspector Practicum, funding for additional needle exchange program supplies, a new vaccine fridge, and a security system. The only item in our budget request that we did not receive funding for was the Recovery and Resumption of Services one-time request. The ministry indicated that they didn't really provide a lot of guidance or direction on what should be included under that funding, and there was a big difference between health units as to what was asked for under this funding. So the ministry has said at this time to manage your costs as best you can within your approved funding. And if you're facing in-year financial pressures, again, that should be communicated and evident in your quarterly reports. And they will consider additional funding in year once you're able to kind of provide that information as to where financially you're sitting and where your pressures are. The last item that we received approval for was capital funding for a new dental clinic in Walkerton. The current plan is to renovate a leased space in Walkerton, which will give us a dental clinic in that area that can provide a full array of required dental services to clients. And the timeline to complete that project is March 31st, 2024. So the main item of discussion around the budget is the 1% increase to the mandatory funding that the province provided us with. So in our budget submission, we did not ask for any increase. However, all public health units were given a 1% growth to their base funding. So this equates to about $90,000 from the ministry. And for 2022, it's going to get prorated from April to December. So it's only for 9/12 of the year. But since the mandatory programs are cost shared between the counties, in order to keep that 1% growth funding, we would require approval by the board for the counties to contribute their share in order to maintain the 70-30% funding ratio. So for 2022, the financial implication to the counties would be $27,364 between the two counties. And that would reflect the April to December, the prorated portion for the year. And then if you had a full fiscal year, so starting in January 2023, it would be $37,000 additional between the two counties for that 1% growth funding that we received from the province. So our recommendation at this point is that the board approve the 1% increase from the Ministry of Health based on our 2023 projections and preliminary budget planning. So Madam Chair, I'll turn it back to you for discussion on what the board would like to do about this.
Thank you. Dr. Era, you have a comment?
Yes, Madam Chair, thank you. Through you, I just want to thank Kim for the summary. I just want to add a bit more detail around one of them, just because it could be understood in two ways. The one-time funding request for extraordinary funding for recovery was declined for all health units, not just for us, based on the fact that multiple health units had significant variability. Just want to elaborate on that one. Thank you.
Okay. So discussion on the 1% increase and asking the counties for their share. Luke?
Do you require a motion, Madam Chair, to approve that?
Yes.
Because I would make that motion.
Okay. Seconder, I have Brian Millen. Any further discussion? So that's carried. So my question, when do you expect to see, I think I heard it, when do you start in Walkerton with the dental? That's good news.
Through you, Madam Chair. So we received a small portion of the funding that we can use this year. I believe it would be for planning, design, permits, that kind of thing. And there will probably be a formal procurement process we'll have to go through for hiring a contractor. So I would expect construction would start in 2023 sometime. Good,
thank you. Helen Clare and then Brian O'Leary.
Thanks, Madam Chair. I just think I missed the vote there. I saw a mover and a seconder, and then you said it was carried. I don't think we actually had a vote, so I just wanted to call that to your attention. Thank you, Madam Chair.
Do you think I'm rushing? Okay, so it was moved by Luke and seconded by Brian Millen. And now I'll ask if there's any further questions. And this is for option one. All in favor? That's carried. Okay, Brian O'Leary, did you have a comment?
Yeah, the same as HC.
Oh, thank you. I'm glad you guys are keeping me on track. All right, so that takes care of corporate services. Thanks very much, Kim. So we do have an in-camera meeting. That's item 12. It's been recommended that the Board of Health meet in closed session in order to discuss labor relations, negotiations, and matters pertaining to a collective bargaining. I need a mover and seconder. Alan and Helen Clare, all in favor? That's carried. Thank you. Mary, you can do your thing. Let me know when we're ready. Now in open session. Oh, see, you didn't stop me. I have to wait for Mary to give me the go ahead. And you guys can decide who wants to move and second it in open. Alan?
Madam Chair, just while we're waiting, just a question for Dr. Aaron, not to put him on the spot. Do you think it's a possibility we would have the next meeting at the boardroom and live, or how long do you think we would like to continue on with Zoom?
The health unit is open for in-person meeting anytime the board wishes.
Madam Chair.
Yes.
We are having technical
difficulties,
but we are live now.
Okay, so I'm good to go. Okay, all right. Welcome back. A closed meeting was held. The one item considered was discussion of labor relations, negotiations, and matters pertaining to collective bargaining. Coming out of that closed meeting, the board has a motion to approve the negotiated contract with ONA. I need a mover and seconder. Brian Millen and Luke. All in favor? That is carried. Thank you. And we have one final motion, and that is to adjourn the open meeting at 12:17. Brian O'Leary moves it.
Madam Chair,
Yes.
just on Alan's point for our next meeting, do we need a motion to direct or direction to have our next meeting live?
I would like to ask Mary to send an email out to everyone and just see how comfortable people are. And we can do both, can't we, Dr. Era? We can do hybrid.
Correct, Madam Chair, we can do hybrid.
Yeah, just in case someone maybe is isolating or whatever, but I'd like to get board members' feelings, how comfortable they are.
Okay, thanks, Madam Chair, and I'll move for adjournment.
Okay, so Brian O'Leary is moving to adjourn and seconded by Alan. All in favor? We are adjourned, and our next meeting is June 24th at 10 a.m. Thank
Have
you.
a good weekend, everyone.
Thanks,
Take care, all.
everybody. Bye now.
Hey, thank you so much, Kaylee, Mary. Thank you, Dr. Zed. I can't hear you. You're on mute.